Okay, thank you, Elliot. If you would start the PowerPoint, I'll work off of that script. Welcome, everyone. I'm so totally excited and psyched to be welcoming you all in today. My name is Dan Andrus. I'm the director of the Substance Use Disorder Treatment Project for the Foundation for Healthy Communities, and partnered with Growth Partners and with Lindy Keller from the Bureau of Drug and Alcohol Services to bring these presentations to you. This one is a very exciting one. We are today going to actually get into some of the roots of the work that is being done at Wentworth Douglas Hospital. Almost 3 years ago, we started a conversation. They had a bold idea. We loved their bold idea. We have loved everything that's happened since then. And those of you who have been regular attendees of these meetings have seen Kelly and Peter before. If you were at the Behavioral Health Summit in December, you were able to see their very, very well done presentation, which was excited and which caused a considerable conversation after the meeting, which was during lunchtime, about how everybody should do this and everybody should know about it. So we've been trying to do that. The title of our presentation today, their presentation, is about the Substance Use Response Team Toolkit. I subtitled it Building Blocks for Organizational Change. This is how they went about doing it. And as you get into the slides, there literally is a graphic about the knowledge content areas. So the intention today is to introduce you to this and to make this an available resource for you. Now, Elliot, if we could move to the agenda. Just need to read the purpose statement to you very quickly, because this acknowledges some of our, actually, if you back up on the purpose to the purpose, let me just do that very quickly.
For sure.
We're here as a community practice to promote the development of interdisciplinary hospital systems to identify, engage, treat, and coordinate services for people with substance use disorder. We're delighted to be partnered with the Bureau of Drug and Alcohol Services, which provides funding and support and so much assistance to us. And it's coordinated by our organization and by our good friends at Growth Partners, who will be not so much in the background this meeting already, but who are there standing by for all of the technical issues. Now we can move to the agenda. So after getting through this by 1:15 and probably several minutes before that, we'll actually tip off to our presenters and they will do their presentation. And I want to take just a moment to talk about the trajectory of the meetings that we have had here, but actually I'm going to ask Lindy Keller to talk about that. And Lindy, I'll hand the mic over to you.
Okay, great. Thank you. I'm Lindy Keller. I work for the Bureau of Drug and Alcohol Services and work, as Dan said, with the other partners in moving this forward and funding all the work that the foundation is sending along to those of you who are part of the contract doing this work. So way back in the beginning of the community of practice, we took the time to say, what does it take to help hospitals make major changes? And the three items that came up that fell on, all the items that came up fell into one of three groups, which was changing the culture, building, finding champions, identifying and equipping champions, and building a team. And since that time, we have looked at some specific topic areas within the area, within this kind of overview of how can hospitals improve their care of people with substance use disorders. We've looked at specifically alcohol, because that's a little different in how it has been handled in the past. We also looked at some specifics like the different levels of care and motivational interviewing. But all of them rest these three topic areas, which were either, changing the culture, helping to get champions, or building a team. We also recently had a presentation that looked at a particular subpopulation. The same kind of issues get addressed there. So what's beautiful about today's presentation is it's a hospital who grabbed hold of that concept of looking at those kinds of changes and built a wonderful program within Wentworth Douglas that has been changing, has made a major change in how people are treated there. So I'm excited to get to see this toolkit that tells the rest of us how we might be able to do similar things in our own settings. So I think that that kind of pulls it all together. We're just moving into a particular model. We are not suggesting that every hospital has to do things the way Wentworth Douglas did, but we do hope that there are things in their toolkit that might help you to think differently about how you can move forward with this work. So with that, I'll pass it back to Dan so he can introduce our presenters. And thank you all for being here. Dan, you're muted.
It is my great pleasure to introduce two good friends, as well as two people who worked very, very hard for 3 years to improve their organization and to really create a model and a pathway for many of us. Kelly Mueller is the Assistant Vice President for Behavioral Health Services at Wentworth Douglas. Peter Fifield has a dual title of the Substance Use Disorder Program Manager and the Integrated Behavioral Health Program Manager. They're both great people. I want to make sure that they have maximum time. So I will hand this over to them for the rest of the presentation, and I will go on mute and stay on mute.
Thank you, Dan. It's been our pleasure working with the foundation and with you. I thank you for the introduction, Peter. And if you want to say anything about yourself in addition before we get going, Pete's going to do the driving, so he's going to bring the presentation back up. It disappeared for me. I don't know.
Yep. So hold on one second.
Okay. All right. And Lindy, I appreciate your introduction, because that's exactly our purpose, is to share with you our journey. It's really our story and our journey. The toolkit, which we'll have available to you, really makes that clear as well. This is our story. We welcome you to take anything out of the toolkit, and we'll talk more about that at the end, that fits for your organization, and don't take whatever doesn't fit. Every organization is unique. This is really just exactly that, a toolkit. You choose what you like, if anything, out of it. And you know, we had thought about how do we get the toolkit distributed, and it is just words on a piece of paper, right, when you send out this document. So our hope in doing this presentation is to really bring it to life and give you some of the background and our story. You can go to the next slide, Pete. So our hope is to provide some lessons learned. When I saw this slide earlier, I thought, you can go back to the other slide for a second, Pete, because I have some really fantastic words of wisdom to share from there too. Don't get your professional headshot done after you've had a forget it, I'm just cutting off all of my hair phase. So that's my first bit of wisdom I'm going to put out there. You can quickly go on to the next slide now, Pete. I hope it gets better for you guys though. So what is the need? Let me start at the beginning of our story. We, Pete and myself, Jen Stout, who's a clinical supervisor at the Doorway, had been having conversations, particularly with our women's and children's unit, a couple of years ago, around the number of patients they were seeing come in with a substance use disorder, and the fact that they didn't really feel like they had all the tools they needed to care well for those patients. And so we were having a lot of conversations around, you know, what can we do to help? And Pete and Jen had done some great conversations and education with their team around trauma-informed care and motivational interviewing. And then at the same time as we were scratching our head about what are we going to do about this, Dan and Peter Ames came to us and told us about this grant opportunity where there was a project to improve the care of patients coming to the emergency department. And I joked, and I think I remember saying at the time, we'd love for the money, but we really don't want to just focus on the emergency department. That's really just a point in time. We really like to look at a system initiative. And as Dan said, they were very supportive of our bold ideas about looking more systemically. And that's really what started a much more in-depth conversation. So for us, really the need was the fact that we were having conversations with our teams about they weren't sure they were competent. They weren't sure they had the rules to care for patients with a substance use disorder, no matter what unit they were on, or what part of our hospital or our health system they were in. And because they didn't have the right confidence, they were then uncomfortable. They didn't have a high level of comfort. And part of that was because they didn't understand what kind of supports and resources were available. So they didn't know what kind of technical supports were available. Did we have robust withdrawal protocols and pain management protocols. They didn't really know who to turn to. There was a lot of talk about, what we need is an addiction specialist. A person, right? One person for our system. We have 3,000 employees. One person could come in and this addiction specialist could fix things for us. And didn't understand what kind of resources were available to the patients, and also didn't understand what kind of resources were available to the staff. We know that the needs are complex when you're working with a patient with a substance use disorder, and oftentimes our staff were left feeling emotionally burnt out or frustrated because they couldn't fix things. And so they were having a lot of emotional reaction to the care that they were providing. So this became the beginning of us trying to figure out if this is the need, what are next steps? Next slide, please. So what we did was we worked with Dan and put together our proposal for what we wanted to do around this grant. And we pulled together a project team. And at Wentworth Douglas, we use operational excellence, we call it OE. It's a structured approach to project management. Doesn't mean that your organization has to use that same approach, but some of what we learned was having a very structured and well thought out approach to how we were going to put a project together made it a lot better, a lot easier. And we started with looking at our allies. As I said, we've been having these kind of conversations already with the Women and Children's Unit. We had a director of pharmacy who was particularly passionate, who was working for us at that time around developing appropriate protocols, what was the right psychopharmacology in terms of addressing our patients' needs. And we started thinking about who are those people, right, that you have that conversation with in the hallway, or who you're in a meeting with, and then you have that meeting after the meeting that we always have, where you really start getting excited and generating some ideas about how we could do things better. And so we really looked at early adopters and pulled them together to say, do you want to be part of this project? And this project really was designing what our initiative was going to be. It was also important at that point to look at it as an interdisciplinary team. So we had several of us from behavioral health. It would have been, easy to just do a project, or seemingly easy to do a project just with us within behavioral health, and then you get just that lens. So we were really fortunate to have a team of people, a hospitalist who had worked at MAT before, a nurse midwife who was passionate about helping initiate their patients in treatment when they were in the birth center. As I mentioned, pharmacy and a nurse from the Women and Children's Unit was also a strong advocate. And so we brought together an interdisciplinary group to really start brainstorming around what our project would look like. And so we had to figure out what our goal was. I just told you what some of our needs were. And really it was to increase awareness, compassion, and knowledge. We realized that that was probably the basis of where people's discomfort was coming from. And that if we could increase those things, that in turn would decrease the stigma, judgment, and frustration that our teams were experiencing. I'll turn it over to you.
All right. So I wish we were innovative enough and had enough foresight to sort of grasp this diffusion of innovation concept that I'm going to speak towards at the way beginning, but it sort of came a little bit later, right? And we just though conceptually found that it was so appropriate that we had to sort of talk about it, because it kind of holds us, it doesn't hold us accountable, it sort of provides us a benchmark in terms of like how well this project could potentially go theoretically and how much progress we've had according to this theory of what's called the diffusion of innovation. So this was popularized by Everett Rogers back in the 70s, I believe. And the idea was that with every new innovation, right, that an organization is trying to deploy, whether it's a widget or whether it's a theory or whether it's a culture change, tends to go through this process. And what you see here on this far left is the innovators, right? This is sort of what we originally started with. Way over on the left end of this, which is really just a standard bell curve if you look at it, right? It's even divided accordingly to the bell curve. The innovators on the far left are what we started with, and we'll speak towards these individual groups, hopefully influencing what we would call the early adopters. And then what we found most recently, if you look at this graph, is this chasm, right? And the chasm seems to be where we are right now, right? We've hit a number of people, which we'll talk about that detail in a second, but it's really, how do you get over this hump? What do you need to do? What are the sort of the strategies that need to sort of take place to kind of bridge that chasm and get to the early majority? And I know this is just an image and it's just conceptual. However, it really feels like as we have made our way through this process, we've sort of like, I feel like we're feeling this thing develop in the way that this graph represents. So just talking really quick about the 4 different parts, right? So going back here real quick, you've got the innovators and the early adopters. You've got the early majority, which tend to be sort of the super social folks, right? They're super social, but they might not have deliberate contact with the other peers that are early adopters and the innovators. So they might be on board and they might be social and they're exposed to this, but there's really not a lot of need for them to change. The late majority doesn't really have the need nor the social connection. And it doesn't mean that they're refractory to change. It just means that they're really, once again, there's not a real need nor there's their exposure. And then you've got the laggards, and those are the 16% on the far right-hand side that are really just opposed to change just in general, whether it's a good idea or bad. And those are sort of, without a doubt, not the ones we're looking to modify any sort of behavior on directly. It's really, we're going to influence from left to right, get this gap, this chasm, get the early majority along, on board, and hopefully getting enough momentum to then influence. You'll get critical mass, if you would, and it influences the late majority. The process, though, right? These are the sort of things that, with every diffusion of innovation process, you've got to have an innovation, right? You've got to have something that's given. So we're not going to spend a lot of time on that, but it could be a widget deployment, it could be new technology, or it could be a culture change project like we're doing. The communication piece is huge, and what Kelly's going to speak towards pretty significantly in this process. And you'll notice in the toolkit, the communication, how we communicate, when we communicate, what we communicate is massively important. One of my favorite quotes ever is, the biggest error in communication is the assumption that it happened, right? This level of communication, this concept of communication is very purposeful, it's very intentional, and it has its own sort of like strategy to it. The social element, that's simply who's doing this beside you, right? And in a hospital system, as you'll see, we've got many different, trying to influence many different departments is it's difficult because the culture of the ED is different than the culture at the pain center, which is different than the culture over at internal medicine primary care, right? So the social element is, how do you sort of diffuse this innovation over different social structures and different cultures? And then the time element is simply, how much time are you willing to commit to this? And over what period of time are you willing to sort of influence and, not influence, provide effort towards the influence of change? All right, now we're back onto we're out of the theory and we're back into the actual concreteness of what we did.
So we brought our team together. We developed our OE process. It's a very specific set of exercises and discussions that you go through to put your project together. And our goal, as we said earlier, was really to increase comfort and confidence. And we knew we had to do that through knowledge, right? Knowledge was going to be powerful in this. And so really we realized we were going to be developing an educational program. And so who are we going to educate? What was the purpose of that education? And I had talked about, well, if we just had an addiction specialist, right, we'd be all set. And we started thinking about how is that one person, right? How would we, and first of all, they're like unicorns. I don't know if anybody's out there looking for an addiction specialist, psychiatrist with addiction specialty, but that just wasn't going to be realistic. So we thought, well, maybe we could create some of our own specialists through some training. And so that's what that was the birth of we need a CERT. We need a substance use resource team. And it's funny, as Pete and I were preparing the slide, the team is a noun, right? We use the word CERT almost like an adjective or a verb sometimes around here. You hear people talk about CERT, it creates some common language. It's something we're going to talk about later, but everybody now knows what CERT means. Might not exactly what they mean, but they associate CERT with education around substance use. And so we thought, well, we'll create a team. So what does the team look like? And we thought, well, maybe we could get 6 people. Would 6 people be enough maybe to be a support to our system. And we thought, okay, that's what we're going to do. Our goal is going to be to train 6 people. And so we continued the project and talking about education modules we'll talk about in a minute. But then at some point, fairly early on, and I think it was Pete who pointed it out, he said, you know what, we already have our 6 members, right? Because I talked to you about the people we had on our team. We had Pete, we had a clinical supervisor from the doorway, we had a pharmacist, we had a midwife, we had a nurse. So when we looked around the room, we thought,